And please let Michelle know when you need slides advanced. One second.
All right, there we are. Sorry about that. I was muted and not able to unmute myself, which is a nice trick for Zoom for people to just mute me whenever they want, which is great. Probably a feature people like to keep around. Thanks for joining. As Megan mentioned, this first segment, we're just going to do some background on what the Oregon Health Plan waiver is generally before we start the 1 o'clock session on more of the substance of what we're considering for the waiver application. So if you've heard this before, feel free to hop off and come back at 1 if you'd like. But glad to see so many folks are on and interested in this. Why don't we go to the next slide? Just for a little bit of background, the Oregon Health Authority was created in 2009 around the vision of bringing them together, the various states' healthcare programs, and to create an alignment and across those programs for one shared vision of a healthy Oregon. And our mission really is ensuring that all people and communities can achieve their optimum health, physical, mental, social well-being through partnerships and prevention and access to quality, affordable healthcare. There's a lot of work we do across the agency to ensure everybody can live long, healthy lives and ensure that they've got access to high quality healthcare. The Oregon Health Plan is only a piece of that, but it's a really critical piece of that. And the waiver is a component of how we run the Oregon Health Plan. And so it's a critical element of our overall mission and vision. This last year, as an agency, we also adopted a 10-year strategic goal of eliminating health inequities in Oregon by 2030. And this doesn't replace our vision or mission, but it really gives us a specific framework for how we need to do our work to really achieve that vision of a healthy Oregon. And so you've probably heard from us more and more, and we'll continue to hear more and more around really centering equity and centering our work in addressing racial injustice and health inequities that we've seen across the state and throughout the healthcare system over the next 10 years. I want to go to the next slide. As a core element of this work, in 2019, the Oregon Health Policy Board adopted a definition of health equity. And that is to ensure that it's defined as Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, gender identity, sexual orientation, social class, intersections among these communities or identities or socially determined circumstances. The definition further goes on to say that achieving health equity requires that there be ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution and redistribution of resources and power, and recognizing that reconciling and rectifying historical and contemporary injustices. For folks who've been engaged with health policy work in Oregon for the last decade, we've talked a lot about something called the triple aim. Those are three broad goals that have driven a lot of the nation's health reform efforts that include improving quality, improving health, and lowering costs. And folks have often said that those are sort of three legs of the stool in order to get to an improved health system. I think we've done a lot of work in that space over the last decade. But what we've realized is that if we don't start with actually a framework of needing to be driving towards health equity, that what we see is improvement in all three of those areas, but not in a way that that all Oregonians experience the same way, and we see disparities and inequities and quality and health outcomes and costs. So moving forward, we're really going to be holding on to this definition and having health equity drive our work as we go forward, including with the waiver. Next slide. So what is Medicaid and what is the Oregon Health Plan? Medicaid is a state federal partnership to provide health insurance to predominantly lower income individuals and families and folks with disabilities. It's a state federal jointly run program. The federal government provides the bulk of the funding, about 3/4 of the funding. The state provides about the other roughly 25% of the funding. The federal government, unlike Medicare, which is administered completely by the federal government, the idea around Medicaid is that states have some flexibility to run programs a little bit differently in a way that meets their state needs, but is aligned with some broad requirements at the federal level. And so each state Medicaid program across the country looks a little bit different state by state. And Oregon's Medicaid program looks different than our surrounding states. But generally, we have to still comply with federal regulations and federal statutes about generally how the program is administered. For the last couple of decades, we've called our Medicaid program the Oregon Health Plan. It was sort of renamed that back in the early 90s when we went through some major reforms to improve the program. About a decade ago, we went through another round of reforms where we changed the delivery system and how healthcare is provided within the Oregon Health Plan, and launched new coordinated care organizations, which were local entities that would be basically the health plans that would combine and provide healthcare coverage to most Oregonians on the Oregon Health Plan, and would cover both medical or physical health care, oral and dental needs, and as well as mental health, substance use, and behavioral health care needs. Today, about 1 in 4 Oregonians receive their health care through the Oregon Health Plan, about 25%. The program has been slowly growing over the last several decades. And while not all low-income Oregonians are eligible, most are. And so we saw a significant increase in enrollment in the Oregon Health Plan when the Affordable Care Act passed about 10 years ago. Next slide. So what's a waiver? As I mentioned, the federal government lays out the broad requirements for all state Medicaid programs. And we have basically a contract, it's called a state plan with the federal government that describes how we're going to run the program within those parameters. Part of the reason that Medicaid is a state federal partnership is because there's an idea that states try to innovate and be able to try different things within their individual states to provide better health care to folks who are on the Medicaid program. So the federal government has a process by which you can ask to waive certain federal requirements to test a new model or test a new way of providing care. The idea is if 50 different states are innovating and trying different things, we can learn from one another. We can continue to find ways to improve care. Sometimes when states find a sort of better way of doing something, that'll actually result in the federal government making it a permanent change to its rules or regulations. So the waiver does not define our entire program, but what it does do is it gives us some flexibility in some places where we otherwise would not be able to do things certain ways under federal law. There's a few examples of things that the federal government can waive. It cannot waive all the requirements. It has a set of certain things that it can waive. Those traditionally have been some ways in which eligibility is determined. They can't add sort of unlimited eligibility, but there is some flexibility in changing some eligibility rules around who's covered, what benefits are covered, how services are paid for. Those types of things are usually things that the federal government has at least some flexibility to offer a waiver or provide a waiver to allow states to do things a little differently than normally is allowed. We've had a waiver in Oregon for the Medicaid program going back to 1994. There's 7 rules specifically that are waived within that. And generally, this is really an agreement between a state and the federal government that in exchange for getting a little bit more flexibility, that we'll promise to do things in a certain way that assure quality remains high, access remains high, and that the program doesn't cost more than it otherwise would to the federal government. So we don't really get to just go ask for all the rules we don't like to be waived. What we really have to say is this rule, we think, is a barrier to us wanting to pilot or run our program a little bit differently, that we think actually would improve quality, improve access, lower costs. And the federal government will sometimes allow you a waiver of that regulation. And in exchange, you have to be able to measure whether quality and access and costs actually did improve over that 5-year period. Next slide. So as I mentioned, we've had a waiver since 1994. About every 5 years, we have to go in and renew it and make changes to it. And so that's the process that we're embarking in right now. As I mentioned, our first waiver was granted in 1994 when we actually renamed the program the Oregon Health Plan, and allowed managed care organizations to deliver healthcare for Oregonians in the Medicaid program. In 2012, we went through another major waiver renewal to allow us to be able to launch the coordinated care organizations that I mentioned earlier. In 2017, we got another renewal of our waiver that allowed us to make some changes to the way CCOs operate, to keep building on that model. And here we are about 5 years later, going in for another renewal. So it's an ongoing process. And as I mentioned, each time we go through it, we need to be able to articulate whether quality and costs and access improved at the same time that we're asking for any additional changes. Next slide. It's important to know that the waiver is not the only way that we can change how care is delivered or improve the experience for members in the Oregon Health Plan. As I mentioned, we have a separate agreement with the federal government that allows us to change rules within the program as long as they sort of fit within the normal general framework. So the waiver is really specific to things that allow where we want to color outside the lines, really. We also have contracts with providers and contracts with CCOs, and a lot of what we want to try to fix within the system or try to address in terms of concerns we hear from patients, a lot of that is just things that go into our contracts or go into our rules at a state level. The waiver really just comes into play when we actually need to do something that's otherwise not allowed under federal law. We know that throughout this process of getting input, we don't expect everybody to understand the difference of what needs to be in a waiver and what doesn't need to be in a waiver. I'm just bringing this up for folks to know that the waiver application likely will not reflect all the input that we've got or all of the problems that folks are wanting to solve, because a lot of it, a lot of the concerns that we hear actually aren't things where we need the federal law or the federal government to change a rule. They're just things that we need to do to better manage the program locally. So we'll be as we're getting input from folks throughout this process, we'll be capturing all of that, and we'll also be putting a summary together that describes if things aren't really a waiver issue, what kind of issue they are, so that we make sure that we get that feedback routed to the right part of OHA to be addressed. Next slide. I hit on this a little bit earlier, but there are some general federal requirements for what must sort of the bare minimum requirements in order to be able to request a waiver. First, a waiver has to be budget neutral to the federal government. And what that means is that we can ask them sometimes to spend money different than they normally would under a Medicaid program, within some limitations, but generally it can't cost them more than it would have otherwise. So if they would have expected that they were going to spend a certain amount of money for Medicaid in Oregon, and we say, well, we want to use that money a little bit differently, they might be able to grant us a waiver to do that, but it can't cost them more money than it otherwise would. Second, I mentioned this earlier, but we have to do a formal evaluation every 5 years of the outcomes and periodic reports throughout the waiver period to be able to describe that quality and access and costs haven't been put at risk as we've gotten that flexibility at the federal level. And then finally, they last 3 to 5 years. Ours tend to have been granted in 5-year increments, but each time we go in, we basically have to renegotiate the entire waiver, not just the new stuff, but things that were in the last waiver that we want to continue. Next slide. So getting to an approval of a waiver with CMS is a bit more of an art than a science. The federal government has really complete discretion to decide whether or not to grant a waiver. They're not required to grant any waivers. As I mentioned, these are really opportunities to be able to have states pilot things and learn. And so but what they waive, there's some things they cannot waive at all, and even the things that they can waive, it's really up to their discretion on whether or not it's something that they're going to entertain. And so usually that you're more likely to get a waiver if it's on around issues that are aligned with the priorities of the current administration, which obviously changes with the president and changes with whoever is sitting in leadership of CMS, which is our federal Medicaid agency. And so it's always important that we're paying attention to what the issues are that they're talking about and can link up. How do we want to make some improvements to the Medicaid program here, and how does that also help promote their goals? And inherently, this ends up being a negotiation. What we'll end up doing is throughout this process is putting together some broad strokes of what we think we would want to ask for in our next waiver. We'll be, as we're getting input from the community and stakeholders, we'll also start talking with CMS and floating some of those ideas by them, and we'll be getting some, hopefully some early signals that on what they might be willing to work with us on, or what are issues that really are non-starters and not things that they would be willing to entertain. And that will help us sort of narrow our scope of what goes in the application, which will be submitted later this year. But once we apply for our waiver, it's inherently a negotiation and an exercise, and them trying to understand why do we want the waiver and what are we going to do with it, and how are we going to evaluate whether it's successful or not. So it's a big back and forth process, and what comes out on the other end isn't usually exactly what we applied for. Hopefully it's still directionally correct and meets our needs, but usually we've got an idea of how we think we might want to do something. They've got an idea of how they would probably prefer to do it, and we go back and forth until we get some agreement. I think that's it for the slides. That's the background. I think we've got about 10 minutes for questions or comments if folks have it before we go into the broader session.
And just to let everyone know, if you can please enter any questions into the chat, we will be pulling those out and asking during the presentation. So we'll hold for just a minute and see if anyone has any questions to add to the chat. The chat function is at the bottom of your screen. It should be on Zoom. If you just click there, you can type your message in, and everyone should be able to see it. Okay, so we're not seeing any questions come in just yet. Just a reminder, this is the optional waiver introductory presentation. We'll begin the rest of the content at 1 p.m. So everyone is welcome to stay or exit the presentation and come back at 1 o'clock, but we'll go ahead and adjourn for a few minutes and end the presentation, and we will start back up at 1 p.m. Please feel free to enter any questions into the chat box if you would like between now and then. Okay, looks like we do have some questions coming through. The first one, where can we find the recording at the 1 p.m. and discussion if we can't be there? So the presentation will be recorded and will be posted to the waiver webpage. That is www.oregon.gov/1115 waiver renewal, which I'll type that into the text here. Okay, the next question. Okay, this question for Jeremy. How do you see the new CMS administrator affecting Oregon's waiver?
Thanks for the question. So we've been, like all states, waiting for CMS leadership to be confirmed. CMS is it stands for, it should be two M's in it, but there's only one. It's actually the Medicare and Medicaid agency. So it's a very broad healthcare agency. And the leader of that, the administrator of that agency is one of the top, one of the biggest appointments that any president makes, and needs to go through Senate confirmation. So just yesterday, the Senate confirmed Chiquita Brooks LaSure, who is now will be the administrator for CMS, which is great news because we've all been waiting for that to move forward so that other key leadership positions with CMS can be filled out. So most important part is now we actually know who the leader will be with CMS and know who we'll be working with, and that will allow some other key positions like the Medicaid administrator to be filled. We're really excited that all the signals we've been getting from the White House and from Chiquita's background are really aligned with what we've been thinking about for the waiver, which we'll talk more about at 1 o'clock. But everything we've been hearing is that they're really focused on health equity, on addressing racial injustice, and on building off of the ACA and continue to move towards expanding coverage. So we've been, as you'll hear about at 1 o'clock, a lot of what we've been considering is in alignment with that. Also, by way of background, Chiquita actually has worked on some projects in Oregon, so she's familiar with CCOs, and so that's always helpful to have somebody who is already familiar with our model and what we've been trying to do with the state. But I think from a values perspective, what we've heard from this administration is very much aligned with where the governor and legislature have been pointing us.